Good afternoon. Thank you for inviting me to speak at the American Academy of Physical Medicine and Rehabilitation, a most prestigious platform. I must thank Dr. Amy West as well for her collaboration and presenting our work at AAPMR last year. I'm sure Amy will revisit a lot of our important messages in her talk today as well. So what I'd like to convey to you is how NeuroHAB evolved and how such a complex condition like back pain, which is of epidemic proportions, can be profoundly simple to cure. Like many other processes, both biological and mechanical, they only seem complex when you don't understand the fundamental principles behind them. For example, the brain, in all of its glory, is basically operating on sodium and potassium ions being pumped across a neuronal cell membrane to create an action potential, allowing nerve cells to propagate electrical impulses, creating productive circuitry and what we know as consciousness. And in non-biological systems too, we can marvel at what our machines do for us, but fundamentally they utilize simple nuts and bolts and physical principles that once understood solve what appear initially to be insurmountable challenges like flight and the computational speed of processing simple zeros and ones, or what we know as binary code, allows computers to become integral parts of modern life. I try to avoid using the term low back pain independently. Low back pain is a symptom, not a disease or diagnosis, and should not be used interchangeably as such. Many articles, researchers, authors, textbooks, medico-legal reports default to discussing low back pain like it is a disease. It reflects global lazy thinking and a misunderstanding of the disease. No different to a cardiologist describing his theories on myocardial infarction and only using terminology like chest pain, or a respiratory physician describing a condition as shortness of breath. It's fundamentally bad medicine to treat symptoms and ignore cause. Attributing biopsychosocial elements to the condition of back pain is confusing associations for causations and unhelpful in regards to curing back pain symptoms. Also think about conditions that are rare versus very common. Complex and infrequent events have to come together at the same time and place to form the perfect storm, which thankfully are very uncommon. Back pain symptoms, on the other hand, are very common, epidemic in fact, and therefore undeniably must have a simple cause. No different to other disease epidemics like TB, malaria, HIV, smallpox, all of which are effectively managed by understanding and controlling the simple root cause. Ignorance of this concept is the likely cause of existing failing treatment paradigms and the reason why I coined the term and hashtag failed rehab syndrome. We all know about failed back surgery syndrome, but if you Google failed rehab syndrome, nothing comes up. It's mind-blowing when you appreciate that of the 1.5 million people suffering chronic low back pain in Australia alone last year, only about 750 had surgery as part of their treatment. Why is there no chapter in every textbook or a single peer-reviewed paper discussing failed rehab syndrome? I think Amy and I are the only ones in the world recognising and openly talking about this condition. Back pain symptoms represent a condition that is being so poorly managed that the WHO considers it to be the leading cause of disability worldwide. It is one of the most significant economic health burdens for industrialised nations. The disability-adjusted life years have increased 54% in the last 25 years. Back pain symptoms are ubiquitous, and it remains clearly apparent that we are failing miserably to manage it. This is the first take-home message for you. If you don't adopt a paradigm shift in the way you manage back pain, you are failing to help your patients. We can't pass that responsibility on to our physical therapy colleagues, be they physiotherapists, exercise scientists, chiropractors, massage therapists, gym or PT instructors. They turn to us, the doctors, for guidance. The patients turn to us for guidance. We, as the patient's doctor, hold the bulk of responsibility and accountability for outcomes. The physical therapy industry, much of which is unregulated, has the luxury of hiding behind a veil of perceived economic affordability, low potency, delayed effect, with associated poor accountability and treatment safety, and when in actual fact it is quite the opposite. Accumulatively, physical therapy accrues millions of dollars of expense and indirectly is harmful by way of delaying effective treatment and potentially entrenching central sensitization. Ultimately, the buck stops with us as the medical professional. We don't have the luxury of saying, I don't think I can help you anymore. You better go back to your doctor and ask for a referral to the spine specialist. In most cases, patients who aren't getting better with PT simply do not attend, so the therapist is none the wiser of the outcomes. And if they do have symptomatic recovery, their symptoms have a 75% chance of recurrence within 12 months because root causation has not been resolved by the delivered treatment paradigm. We need to take charge of the physical rehabilitation therapy that is delivered to our patients. Otherwise, we are absconding our duty of care. Why did I develop NeuroHAB and functional movement therapy? As a spinal surgeon, I would see 15 to 20 patients a day. On average, 1 in 30 patients would have a spinal structural problem amenable to surgery. The vast majority of patients are therefore suffering pain symptoms with no identifiable structural cause. That was my light bulb moment. If the patient's condition and symptoms were not secondary to a structural problem, it had to be a functional problem. Later on, I also realized that even the surgical patients who did have symptomatic structural compromise were also afflicted with a primary functional disease. They were just further along the functional disease spectrum with secondary symptoms from spinal instability or neural compression that required surgical correction. Therefore, 100% of patients with chronic back pain symptoms, whether requiring surgery or not, are suffering from a primary functional disease. So the back pain puzzle pieces are still a little bit scattered for me at this stage in 2012, 2013, but they're starting to take shape in the evolution of NeuroHAB. I had conceptualized back pain symptoms being secondary to a functional disease and eliminated terms like non-specific low back pain from my vocabulary. Sadly, it is still quite broadly used in peer-reviewed literature and the back pain therapeutic industry. It needs to stop. The next step and principle to conceptualize relates to defining the functional disease causing back pain symptoms. If we consider what the primary purpose of the musculoskeletal system is, we need to ask, why do we have bones, ligaments, tendons, muscles, and joints? I'm sure everyone will say and agree without conjecture that movement is the primary function of our musculoskeletal system. If you are a land organism without a musculoskeletal system, you aren't moving very much. The last time I saw a slug in the garden, it was still there the next day. So suddenly, another penny dropped for me when I realized that if the musculoskeletal system's function is movement, then a functional disease causing back pain symptoms must be movement dysfunction. So around 2013, I began asking my regular physiotherapist or exercise physiologist to treat my patient's disease of movement dysfunction. It was a dismal failure, unfortunately. Patients would be no better after frequent attendances with my industry-leading physical therapists, and understandably, they would often be frustrated, angry, and depressed because very often I was seen as the last hope and unfortunately the last referral in a line of many. And here I was explaining to them that their spine was structurally fine and all that had to be done was to fix this condition called movement dysfunction and they would be cured. That wasn't the case in the early days. I then interrogated patients and my rehab providers with what treatment they were actually receiving. In every case, it was centered around couch-based recumbent therapy, manual therapy, soft tissue release, stretching, massage, gym-based core work and range of motion exercises, also mostly in the recumbent position, such as clams, hip thrusts, planking, wall squats, or clinical Pilates. Active avoidance of intensity was a universal theme. Sessions were scheduled daily. An inordinate amount of dry needling, prolotherapy, acupuncture, and medically driven interventional pain blocks, inclusive of epidurals, facet joint blocks, radiofrequency ablation, was being delivered by other medical professionals along the way. I'm sure you will be familiar with these procedures and the lucrative economic revenue for proceduralists at the expense of taxpayer-funded Medicare. At this point in my life, I was transitioning my own sporting interests from similar gym-based core strength exercise and turning to Olympic weightlifting. I very quickly recognized that regardless of how fit, big and strong an individual was, it was not the discriminator of a successful, perfect clean and jerk or snatch. The best Olympic weightlifters are those who are most coordinated and who have the least movement dysfunction for that task. I made the connection that if these compound movements allowed you to move very heavy objects very quickly and long distances and make you feel and look great, why do we not integrate the same biomechanics in everyday life? So more light bulbs switched on in my brain, and I became obsessed with learning, defining, understanding and teaching these movement points of performance for Olympic weightlifting and making them transferable to everyday life activities by creating reproducible, attainable guidelines that even my aging mum could adopt and apply to her life. The synthesis of my observations and research was that default provision movement was characterized by these 5 very simple key movement points. These form the cornerstone of our NeuroHAB program and underpin our success. If we stray away from these default movement principles whilst performing tasks that are at the threshold of our functional capacity, we will, without exception, experience musculoskeletal injury. Chronic incompetence at expressing these NeuroHAB movement points of performance will unavoidably and progressively reduce functional capacity. And when it falls below the functional demands of a task or life in general, which represents the individual's injury threshold, pain symptoms and disability will occur. This explains why a young 20-year-old furniture removalist moving poorly can handle his work similar to someone moving well. But the difference is that the person moving poorly will never have a long career because his functional capacity quickly falls below the functional demand of a physically demanding job. He will need to maladapt into more sedentary work to remain gainfully employed, or more often than not, become unemployable in the near future. The person moving well will gain functional capacity as he ages and performs those physically demanding tasks. He will have a long career and remain pain-free. He only needs to retire when functional capacity is compromised by sarcopenia of aging. Even then, if he tries to lift a heavy object while maintaining the above movement points of performance, he won't injure himself. The object simply fails to move. I was now able to reflect back on the therapy that my patients were receiving for my new diagnosis of movement dysfunction and compare that with NeuroHAB-defined movement proficiency. Not one element of their rehab was upskilling them to move proficiently. They may have been getting a stronger core or marginally more mobile, but these quantitative structural focused attributes were doing nothing for the qualitative functional movement deficits driving their chronic back pain. Strength does not mandate movement skill. Tiger Woods at 5 could hit a golf ball further than Mr. Universe, yet he was obviously not as strong. My objective is to make my patients more skillful at the all-important sport of life, in which they are all participants of. I remember very well talking to the owner of a multi-franchise leading sports and spinal physiotherapy service that looked after most of my patients, and I said to him, "You're not reversing my patients' movement dysfunction. They've had months, sometimes years of treatment with your team, and they still move terribly and remain in chronic pain." It was like talking Chinese to an African. He just did not understand what I was getting at or the concept of movement dysfunction. I then realised that mainstream rehabilitation was not geared to deliver specific and distinctive movement therapy for my patients. I have not referred a single patient to conventional passive rehabilitation or core strengthening exercise for 5 years now. Why was he unable to deliver movement therapy? Awareness, education, knowledge, skill set, experience. Why don't they acquire the skills? The current economic business model and even the facilities for delivering mainstream passive and active physical therapy are not set up to deliver NeuroHAB. These are significant obstructions to the necessary paradigm shift in management. We collect Oswestry disability scores on all of our patients who are the worst of the worst and chronic and centralised to varying degrees and biased to failure based by the fact that they are entering our program after being referred for a surgical opinion. Our patients are the ones who have not improved spontaneously with corner store Pilates, massage and deep tissue release. We generally won't see those acute or subacute pain patients until they eventually become chronic. When they do get to us, they are biased to failure. This is reflected by an average starting Oswestry disability score of 30%, indicating moderate to severe disability, and after 8 weeks of NeuroHAB, an average halving of ODI scores is observed. We have no exclusions other than MOBs, which stands for Movement Obstructing Barrier. If a patient has an MOB, it needs to be reversed in order to participate in movement therapy. MOBs are generally rare, but include structural deficits, spinal instability, intolerable symptomatic neural compression, severe weakness, and intolerable pain, limiting even minimal proficiency limited range of motion. I'm constantly surprised by patients who cure their movement dysfunction and back pain symptoms when at first I think they have an MOB. I am now offering NeuroHAB to patients that previously would not have been considered for conservative management, even those with neural compression. Rachel here represented one of these patients who started the program so incapacitated that I didn't think she'd improve. But incredibly, with the progressive nature of NeuroHAB, she improved steadily to eventually reach athletic status in 8 weeks. Carol was offered major spinal stabilisation surgery elsewhere for her chronic low back pain symptoms of greater than 10 years. She was referred to me for a further opinion, and given the significant focal structural breakdown at L2-3, I thought surgery would be a requirement in addition to NeuroHAB. We started the NeuroHAB program first in preparation for surgery, and I was amazed to observe that proficient movement therapy and her application of this into her activities of daily living reversed the disease of movement dysfunction and subsequently reversed her pain symptoms such that surgery was not required. Carol was The hardest part of helping patients with their back pain symptoms is reversing the misinformation that has been entrenched in them over years by our industry, delivering failed rehabilitation syndrome and attributing treatment failure to factors like degeneration and bulging discs, body weight, age, inactivity and sedentation, or ironically overactivity and physical labour. Weak core, arthritis, tightness, scoliosis, leg length discrepancy, and the list goes on. So when the patients come to see me and I don't want to address any of these elements, it's very hard to guide them toward movement therapy because it's never been broached before and completely foreign to them. Why has my physio who works with the Olympic swimming team never told me about this movement therapy you want me to do? We do not cure the disease of movement dysfunction. We must make the patient accountable for their own recovery and make them realise that we as doctors will not cure their low back pain. There is no magic pill, injection, adjustment or surgery that can be offered. We can only provide them with a very simple but effective roadmap to recovery, but they must make the journey, and for some it may be a long journey, after 10 to 20 years of chronic back pain symptoms, with many speed bumps along the way. Having a roadmap, even if it is a long journey, is far superior than being lost with no guidance, going around in circles, which is exactly how many patients feel. Only they can upskill their body to fix itself once we eliminate the movement dysfunction, limiting the body's incredible spontaneous healing potential. Aging and other degenerative changes do not cause back pain symptoms. One of our city's leading professors of pain medicine told me recently at a meeting that age and degeneration is the cause of low back pain, and this justified his procedures of facet joint blocks and radiofrequency ablations. When I asked him why young people have just as debilitating back pain symptoms as the elderly degenerate spine does, he agreed with the observation, but said, "Not as often though." I said that's like saying dry grass causes bushfires more often than green pastures cause bushfires. It's a crazy notion for a professor of pain medicine to entertain. Of course something else is at play that sparks the ignition of a fire or inflammation. Having degeneration or dry grass makes you more susceptible to the inflammation, but only by association, not causation. And having this mentality prevents you from ever realizing the true cause of the inflammation. Degeneration is as normal as wrinkles and grey hair. Our wrinkles and grey hair are not painful, and neither should our normal spinal degeneration. But if we subject our spinal degeneration to movement dysfunction, pain-free degeneration rapidly transforms into painful degeneritis, just like our wrinkles become painful if subjected to excessive ultraviolet light, which we call sunburn. Back pain is not cured at any functional movement training centre. We are only successful when our patients realise that getting out of bed proficiently is their rehab. Sitting, standing, bending forward to brush their teeth, stacking the dishwasher is their rehab. NeuroHAB gives patients the tools to make every second of every day rehabilitation, which becomes profoundly powerful and effective. My heart sinks when patients come in saying, "I do my exercise for 30 minutes every morning, doctor, and I'm still not getting better." They have not been given the right message. How can 30 minutes of whatever exercise they are doing reverse 16 to 18 hours a day of poor movement, driving inflammation and declining functional capacity over the preceding 10 years? Of course it will fail. Implementation of movement therapy and NeuroHAB should not be delayed, and therefore engaging in therapies like conventional passive physical therapy or exercise, although not directly harmful, putting aside the potential promotion of central sensitization, it does delay acquisition of skillful movement therapy. Movement dysfunction to the musculoskeletal system and spine is like smoking to the lungs. The quicker you reverse it, the quicker and more completely you recover. Patients who are severely and chronically affected by movement dysfunction may never recover because of entrenched, centralized, maladaptive pathoneurophysiological pain mechanisms analogous to a patient's acquired emphysema never being able to resolve even after he stops smoking. Functional capacity is the ultimate metric of health. Never mind blood pressure, triglycerides, body weight. If you have a high functional capacity, all of these surrogate metrics of health will be optimal. Think about this fundamentally. If you have to lift something or do any task like mow the lawn, stack the dishes, or execute your job, if you don't have the functional capacity to meet the functional demand of the task, but persevere with the necessary task like going to work, you will develop pain symptoms as your body naturally warns you of the imminent and potential threat. A common treatment paradigm is to advise patients to reduce their functional demands in order to bring the system back into equilibrium. The treatment mantra actually promotes maladaptation. If it hurts, don't do it, or you can't continue to work in that career anymore, without resolving the issue of why has my functional capacity declined. It leads to a never-ending cycle of increasing quality of life restrictions to keep functional demands in check with poor and declining functional capacity to avoid pain. The better solution is not to maladapt by reducing functional demand, but rather to increase functional capacity to meet the functional demand. The key to increasing functional capacity is that it needs to be acquired on a foundation of movement proficiency. If you try any other way, it will lead to further pain and further decrease in functional capacity. No MRI ever caused harm to a patient's spine. Misinterpretation and providing misinformation to a patient about MRI findings, on the hand, is harmful. There is a powerful movement from leading researchers sending messages to the health industry, the public, private health insurers and government, discouraging imaging and surgery for low back pain. This reflects a deep ignorance of causation and also ignorance of the epidemiology of the condition, with only 0.05% of chronic back pain sufferers ever receiving surgery. Economic purse string holders receiving these incorrect pseudoscientific recommendations will of course jump at the opportunity to save money. It is nearsighted and may save a few dollars in the very short term, but in the long term, many patients will suffer and the prevalence-related costs will rapidly catch up if these draconian-like policy changes are implemented. Surgeons should be telling their patients that surgery does not cure back pain symptoms. How can it? You can't cut out or fuse pain away. Surgery is a 100% structural repair when in fact the cause is functional. This does not mean that patients may not require surgical fusions for their back pain condition, but the critical element is that after surgery, the functional problem must be effectively addressed. So don't refuse to fuse, but I implore you to ensure your patients understand that surgery is just a stepping stone to curing the movement dysfunction cause of low back pain. Virtuosity refers to relentlessness in coaching. We are not happy with near enough is good enough. In even the most simple hip hinge task, virtuous movement means being uncommonly exceptional at common unexceptional tasks like sitting, standing, bending, squatting, which are the building blocks of activities of daily living, and more complex tasks that comprise what I referred to earlier as the sport of life. Drilling the 5 NeuroHAB movement points of performance allows the patient to produce central nervous system driven motor patterns that manifest in virtuous execution of these movement tasks, laying the foundation for the unavoidable improvement in functional capacity. Restoration of functional capacity is observable in this chronic pain patient after he learns how to move correctly. Default proficient movement is distinct from mandatory proficient movement, but you need to earn the privilege to move poorly and earn the capacity to control the spine in poor positions that breach NeuroHAB guidelines. Our goal is the slow, steady and progressive modification of CNS motor patterns, hence the term NeuroHAB. It is no different to learning a new movement skill like piano or juggling. It is hard work and very demanding on both patient and the movement therapist, especially in the early classes when pain levels are high and capacity low. For chronic back pain patients, our program is 8 weeks and consists of 2 one-hour classes per week. We start with a simple assessment task that is repeated at the end of the program. These are the water bottle test and the sit to stand. We have also investigated digital analysis of movement at the beginning and end of the program utilising Dorsa V wearable movement sensor technology. All patients fail these primary tests at the beginning of NeuroHAB movement therapy. The transformation is phenomenal toward the end of the program. The grey, black and red movement traces are completely different at the beginning of the program compared to at the end of the program. An indispensable tool integrated into every class is the $4 broomstick. It serves as an aid for patients to learn about the neutral spine position. We want 3 points of contact with the occiput, interscapular region and sacrum. This is maintained as patients go about their drills to coordinate posterior kinetic chain activation, hip-centric rotation and unloaded knee positions. The hip hinge remains the foundational movement to learn NeuroHAB. Performed correctly, it exemplifies NeuroHAB proficiency, regardless of range of motion and power, such that any patient who does not have a true MOB can perform it. It can take some patients the better part of 4 to 6 weeks to become confident with this movement and express it as their default bending movement as opposed to a corrupted motor pattern, knee-loaded movement. We make a conscious effort to scrutinise every patient when they are not aware we are observing them, such as when they bend forward at the drinking fountain or go to pick up their bag at the end of class. Often patients displaying the skillful movement during class falter when they are performing simple tasks with movement dysfunction creeping back. This is a very opportunistic moment to highlight that every second of every day should be seized upon as a rehab opportunity. That's better, yeah. So, once motor patterns correctly initiate posterior kinetic chain powered proficient movement, we can progress to sit to stand and squatting. Initially, the range of motion has to be significantly modified because soft tissues simply are not conditioned to enable sitting in a normal chair with the correct technique. So we elevate boxes during drills. We also encourage this at home with dining room chairs, for instance. As movement proficiency is maintained with necessary range of motion restrictions, soft tissue steadily becomes stronger and healthier, and protective hypertonia subsides, affording a reversal of the sensation of tightness that never settled despite years of stretching and deep tissue release. Patients are in awe of their restored range of motion. We can then remove height restrictions and continue the process, repeatedly reinforcing NeuroHAB movement proficiency, integrating more loads, extending range of motion, and challenging movement tasks like wall balls, deadlifts, kettlebell swings, ring rows, rowing, and eventually intense Olympic weightlifting. Not for the purpose of building strength or fitness, but for the purpose of challenging the nervous system to acquire skillful, coordinated motor patterns, manifesting in movement proficiency for everyday life activities. Eventually, relative intensity becomes a significant experience for all patients, regardless of age, from teenagers to nonagenarians. Intensity is actively sought for the health benefits of multiple neuroendocrine hormonal responses, endorphin release, type 2 muscle fiber stimulation, and neurophysiological and musculoskeletal favourable adaptations. In summary, this means your body and everybody is curing movement dysfunction, regaining functional capacity, and reversing the root cause of back pain symptoms definitively. Simple, effective, affordable, safe, which equates to good medicine. Thank you all for listening, and to my team for their commitment to guiding our most challenging patients back to health. We are honoured and privileged to be entrusted with the health of our patients and take accountability for outcomes. We appreciate your belief in us when we say that this post from leading researchers in Australia is a load of nonsense. Thanks very much.